Good afternoon, everyone. We are just waiting for Sanjeeva sir to join the session. Please give us 2 minutes. Can we start the recording, please?
Ma'am, please make this in a full screen mode.
Good afternoon, everyone. IGICH India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the National Guidelines for HIV Care and Treatment 2021. Today's topic is management of HIV exposed infants and children and management of newly diagnosed HIV infection in children, including ART initiation. Today's speakers are Dr. A.K. Puri sir from NACO, Dr. Anju Seth ma'am from pCoE KSCH, and Dr. Sanjeeva sir from pCoE IGICH. We welcome you all for today's session. I now request Dr. Puri sir to please give the opening remarks.
So I welcome all the participants and speakers, Dr. Anju Seth, Dr. Sanjeeva, and all the IGICH partners and our NACO team. And it is an important session. And that reminds me that we should also start some session for our DACOs, district TB, district AIDS officer, those who are actually district TB officer, but they have been assigned an additional job of HIV AIDS, and their hand holding is also very important. And through this NDLS, we may start this session also, and it will be a very good session for them. We can prepare a brief and we can utilize, as Dr. Anju said and Dr. Sanjeeva has joined, so that they will be giving, they will give their inputs on this remark. And further, I would like to say that this is today we will be talking about the management of HIV exposed infants, children, and newly diagnosed HIV infection in the children, including ART initiation. And we are going to discuss about the parent-to-child transmission risk of HIV with or without intervention. As you know, with intervention, and there is a lot of difference between with intervention and without intervention. With intervention, we can brought it to as little as 1%, and without intervention, it may go 20 to 45%, depending upon the risk. So that is important. Care of HIV exposed infant, children, feeding guidelines for the infants below 6 months, 6 to 18 months, and there are 6 criteria to assess the suitability for the replacement feeding. Those criteria needs to be looked into. So, and also we'll discuss about the mixed and complementary feeding, which are very important. Although it looks very simple, but it is in day-to-day life, your dealing, it will be useful for the infants, those who are exposed to the HIV. So infant based on the low risk, high risk, and immunization, vitamin A supplementation, current national immunization schedule, etc., will also be discussed, and the diagnosis of HIV infection in the infant and children, along with the clinical criteria for presumptive diagnosis of severe HIV disease in the infant and children. Determining the clinical and immunological staging, red flags for the development, screening, evaluation, assessment of adolescent living with the HIV, antiretroviral therapy, and children with first-line regime. Now I welcome the speaker, Dr. Anju, Seth, and Dr. Sanjeeva. Over from my side. Thank you.
Thank you for the opening remarks, sir. We have noted the training for NDLS training for the NACO people. I now request Kiran to please run the pre-test. Thank you. Participants are requested to please go through the pre-test questions. There are 5 questions in all. Please scroll through the questions and answer all the questions. We have 5 minutes for the pre-test. Also, kindly note, attendance will be marked for the pre and post-test. So please remain till the end of the session. Participants are requested to please start attempting the pre-test questionnaire. The questions are now visible on your screen. We have another 2 minutes for the pre-test. Kiran sir, we can end the e-poll now. I now request Anju ma'am to please continue the session.
Hello, Kiran. Am I audible?
Yes, ma'am.
Yes, ma'am. Yes.
So, should I start?
Yes, ma'am, please.
Okay. Can you bring my slides on? Good afternoon, friends. Today we have two sessions dealing with children with HIV. And as you know, we are IGICH has organized a series of national distance learning seminars disseminating the new guidelines. So today we are beginning with the pediatric guidelines, and the first session is going to be on HIV exposed infant, and the second one is going to be on evaluation of a new child diagnosed with HIV. So if you have any doubts, these you please note them down. You can write the questions. I'll try and answer them at the end of the session. I'll be taking the first session. Next slide, please. Can I do it? Kiran, can I forward them myself? या आप करोगे?
मैम यहाँ से मुझे करना होगा.
आप करेंगे. Okay, fine. So this is chapter 3.1, and as you are all aware, what we understand by the term HIV exposed infant is these are children who are born to women with HIV infection till we are sure whether they are infected or they are not infected. So as you know, these children are vulnerable to get infection transmitted from the mother at various stages, right from in utero period to the labor until they are being breastfed. So unless HIV infection can be reliably excluded, that is, they are no longer exposed to the risk of acquiring infection, or it is confirmed, we use this term HIV exposed infants. Next slide, please. So just to begin by having a look at what are the kind of numbers we are dealing with. We currently, this is the 2020 estimates. We have about 81,000 children living with HIV in India, constituting about 3.5% of the total HIV load of the country. 10% of the newly diagnosed HIV infections during the year 2020 were in the children. And as we have seen with our adult HIV infection rate, there is, we are fortunate that there is a 55% reduction in the annual new infection rate in children. Next slide, please. I'm being told there is no sound. Am I audible?
Yes, ma'am.
Okay, I think
Yes,
somebody wrote there are no, it's not audible. So just a quick look at the statistics. What I would like to bring out in this slide is of the total 23 lakh people living with HIV, as we discussed, about 81,000 are children, constituting about 3.5% of the total HIV load. However, the total, if we look at the deaths, the total deaths are 28,361, of which children constitute 3,582, which is around 12%. Okay, so while children constitute 3.5% of total HIV load in the country, they contribute relatively more to the deaths. And that's something we need to keep in mind, that children are more vulnerable to die because of HIV infection. Next slide, please. As we are aware, mother-to-child transmission is the overwhelmingly important reason for HIV infection transmission in children, accounting for more than 90% of all cases. So if we look at the current estimate, we have about 30 million pregnancies in India every year, And out of these, about 20,000 odd pregnancies occur in women with HIV infection. Infants born to these women are at risk of acquiring the infection from the mother. So what we really need to do is, among all these 30 million pregnancies, recognize who are these women, these 20,520 women who have HIV infection. Some of them will be knowing their HIV status. Quite a proportion, large proportion, may not be knowing their HIV infection status. They may be asymptomatic and yet carrying the infection. We need to recognize these women, because in the current times, we have very good antiretroviral prophylaxis available to prevent mother-to-child transmission of HIV infection. If we follow the best practices, we can bring down the HIV transmission rate to less than 2%. And look, where are we right now? In the year 2020, mother-to-child transmission rate was still crossing 27% in our country. It is much better than 40% that we had in year 2010, but we are still way more than what we are capable of achieving. So a lot of work has been done, but a lot more still needs to be done. And the best way that we can do it is by recognizing HIV infected pregnant women so that they can be offered the whole comprehensive package of care to the pregnant mother and to their infants that will optimize the outcome for these infants. Next slide, please. So in the current time, as you're aware, we are now giving all HIV infected pregnant women 3-drug ART, beginning as soon as we detect the infection in the mother. And in addition, we are giving single or a double drug prophylaxis to the infant. We'll be talking more about it. And if we actually follow this kind of a robust regime, we can really practically, eliminate mother-to-child transmission of HIV infection. Look at the low rates that we are capable of achieving, but we are still some way away from there. And we all need to work together on that. And the most important message that I want to convey to the people here is catch the pregnant women. Catch all the pregnant women, offer them HIV testing. And because this is the only effective way of offering them all the services. If we miss them during pregnancy, we will get to know them only when the child comes to us as a symptomatic patient, and by then it is too late often to help the child. Next slide, please. So why are we talking about HIV exposed infants? We know most of them are not going to be infected. We want HIV exposed infants to be kept under care because irrespective of their own HIV status, these infants are at an increased risk of malnutrition, developmental delay, and repeated infections and related morbidity and mortality. This is because of multiple reasons. There are, adverse social economic factors. There is poverty, broken home, parental sickness, drug abuse, stigmatization. And these factors often contribute to the overall health and nurturing of the child. And there is, as we are aware, the disease, HIV disease, progresses very rapidly in young children, especially in the first few months of life. So if we are not catching them early, we may, and if we catch them when they are sick, before we can offer them ART or before the ART becomes effective, we may actually lose these children. Next, please. So this is the mortality rate in infants with HIV without care and treatment. So if we don't offer treatment to a HIV infected child, nearly 1/3 are likely to die during the first year and nearly half of them by second year of life. And this is a preventable mortality. Next slide, please. So let us see how we can look after the HIV exposed infant so as to optimize their outcome. Next slide, please. So we'll look at the following headings: immediate care at birth, infant feeding, ARV prophylaxis, immunization, co-trimoxazole prophylaxis, assessment of their growth and development, EID, and the follow-up schedule. Next slide, please. Now, what is the immediate care that we need to give to HIV exposed infants? The first thing we should know is we may not always know the HIV infection status of the mother when she comes for delivery. Therefore, we should always treat every mother as potentially infected. Any woman who comes to us in labor, please treat her as potentially infected. By that, I mean, please follow universal precautions. Okay. And of course, most of you who are attending this seminar are not going to be actually there in the delivery. But nevertheless, you can convey to your colleagues, and the care given to a baby who's born to HIV woman with HIV infection is essentially not different from the care that you would give to any other child. So you would wipe the baby's mouth and nostril as soon as the head is delivered, handle the baby with gloves until all secretions have been washed off. Clamp the cord soon, avoid milking, cover the cord with gloved hand and gauze so that there is no blood splattering, and initiate feeding within the first hour of birth according to preferred and informed choice of the mother. This is important, that preferred and informed choice regarding infant feeding should have been decided well before delivery. This just after delivery, when the mother has been through a very difficult time, she's tired and exhausted, it is not the time to discuss what feeding option do you want to go in for. This should have been discussed in pregnancy itself. That's a very important message here. Next slide, please. So in the current times, if we want to ensure the greatest HIV-free survival for our infants, a combination of breastfeeding and ARV interventions, as we are going to discuss further, offers a highest chance of HIV-free survival. So we would say exclusively breastfeed all HIV-exposed infants. These are the guidelines for even infants who are not HIV exposed. For every infant, if we really want to optimize their outcome, exclusive breastfeeding is strongly recommended globally for the first 6 months of life. So the guidelines for HIV exposed infants are no different. So let us give them exclusive breastfeeding for first 6 months. After 6 months, start age appropriate complementary feeding. What about alternate infant feeding options? Should we be talking about it? Yes, it is important, because whatever we may do, we cannot theoretically eliminate completely the risk of HIV infection transmission through breastfeeding. When we give mother antiretroviral drugs, she continues to take them, her viral load gets suppressed, her breastfeeding viral load also goes down, and the chances of infection transmission from the mother to the baby really goes down. However, we can never confidently say it is 0%. Therefore, because breastfeeding carries with it highly reduced, but still a risk of transmission, we must inform the family about that risk. We must tell them the benefits of breastfeeding, and we must, however, still tell them the small risk of infection transmission. And what are the alternative feeding options? What are their advantages and disadvantages? This should be discussed with the family before delivery, during pregnancy. The evidence so far has shown very clearly that in our country, exclusive replacement feeding, though of course it eliminates the chance of infection transmission through breastfeeding, this strategy has now found to be a viable public health strategy in India because of inherent risks associated with exclusive replacement feeding. Next slide, please. So these are our national guidelines for feeding HIV exposed and infected infants. Mothers should be motivated to provide exclusive breastfeeding for first 6 months. Now, in a situation, sometimes that happens that exclusive breastfeeding may not be possible. For example, mother has multiple births, there are twins, or if for some reason mother must join back work, so she may not be able to, despite her best options, despite trying her best, she may not be able to give. In such a situation, we should not stop breastfeeding. we can say that she can continue to breastfeed while starting mixed feeding. This is an important message, which is different from the message we used to give earlier. The reason for this is because we are giving such good antiretroviral therapy to the mother, the viral load is so much reduced that in this situation, the chances of infection transmission from the mother to the baby really go down. And breast milk has so many other benefits to offer. So in a situation that mother cannot breastfeed for 6 months exclusively, let her breastfeed exclusively for as long as she can, and for the remaining time she can introduce top feeding and continue breastfeeding. This is a change in guidelines. Okay. HIV infected mothers of HIV negative or status unknown infant should exclusively breastfeed their infants, introduce complementary feeds thereafter, and they can continue to breastfeed for as long as they want. And the guidelines for the normal population, the HIV unexposed population, is breastfeed for 12 to 24 months. It continues to be now the same for HIV infected women also. Breastfeeding should be stopped only once a nutritionally adequate and safe diet without breast milk can be provided. A lot of children, so we begin complementary feeding at 6 months, build it up gradually. In general, a child by the age of 1 year should be able to eat everything that is cooked at home, and gradually we build up the complementary feeding and stop breastfeeding. Okay. Exclusive replacement feeding should be considered only in situations where for some reason breastfeeding cannot be done. For example, it's say adopted baby, or say it's the baby is the mother is sick and she is not able to breastfeed, or mother has expired. So these are the reasons where exclusive replacement feeding may be considered, or if upon discussion the individual mother or family opt for replacement feeding despite all the evidence that we give them. Next slide, please. So breastfeeding has a lot of benefits. I will it contains all the nutrients that the baby needs. It's easy to digest. This milk is kind of custom made for human infants, and breast milk would protect the baby from infections like diarrhea, pneumonia. It's very convenient, readily available, does not require preparation. It also helps mother-infant bonding, helps the mother recover from childbirth. There are so many advantages of this. However, the risk of acquiring HIV infection, however little it may be, does remain for as long as baby is breastfed, and that's an issue we cannot ignore. Exclusive replacement feeding, of course, has the advantage of no risk of HIV transmission through feeding, and also, one can involve other members of the family when mother needs help for feeding. But there are so many problems with exclusive replacement feeding. First of all, the expense of obtaining appropriate milk, water, fuel, cleaning the utensils, and babies are at a higher risk of contracting diarrhea, pneumonia, and other infections. In fact, a study from our own center had shown that despite a lot of counseling, the chances of diarrhea and other infection remains high if the child is being given top feeding. So that's always a problem in a country like India. So that's a big disadvantage of top feeding, apart from, of course, the cost. Next slide, please. So when when a family is opting for replacement feeding, we need to look at all the factors. If for that family it is feasible actually to carry out exclusive replacement feeding for 6 months. So we need to see that they have access to safe water and sanitation. They economically, the family can afford to provide sufficient and sustained milk replacement feeding. And the mother and the family is capable of frequently preparing feed in a clean manner and administering it to the baby in a hygienic way. They can continue to do it for first 6 months, and mother has access to healthcare services and she has support of her family. A lot of factors actually need to be viewed by our counselor, and while deciding that this family, yes, can actually give replacement feeding. So we have to, during pregnancy, help the mother, guide and help the family in choosing the correct feeding, optimum feeding strategy that is applicable for their situation. And whatever option the family chooses, we must support the family in carrying out that particular option. Next slide, please. As I said earlier, in continued presence of maternal ART, mixed feeding is also rendered safe and may be preferred over no breastfeeding at all. Next slide, please. So complementary feeding, I will not spend too much time on it, except to say that the guidelines are exactly the same as they are for other children. So we introduce complementary feeding at 6 months of age, begin with small amounts of food and gradually increase the quantity as well as frequency as the child gets older, while still continuing to give breastfeeding. So as the child gets older, we kind of change the consistency of the food. Initially, it may be mashed. Later on, it can be chopped food. So we should actually aim to feed a variety of nutrient-rich and energy-dense foods from the family pot, and ensuring that the child gets a diverse diet so that all his nutrient needs are met. And use iron-rich complementary foods. In fact, if we give a good balanced diet, vitamin and mineral supplements may not be required. Practice responsive feeding, which means one doesn't really need to force feed a child, but go by the child's cues. If the child is hungry, offer him feed. Let a child beyond 1.5 years try and eat himself, and let the meal time be a bonding time between the mother and the child rather than a stressful time. Make sure that good hygiene is proper food handling is followed while preparing as well as administering. Breastfeeding should go on. Only it should be stopped when nutritionally adequate, safe diet without breast milk can be provided by complementary feeds. So, as we'll be talking later, we should assess the nutritional status of the child regularly, and we should see if the child is growing well. Remember, a child who's HIV infected, just because of presence of HIV infection in him, he may require extra calories just so that, because there is a state of catabolism in the body when there is HIV infection. So extra calories need to be given. Next slide, please. Let's now come to infant ARV prophylaxis. Next, please. So these are the new guidelines on infant ARV prophylaxis. And we must make sure that our team in the hospital where the deliveries are occurring, where the pregnant women are being followed, the PPT-CT counselors as well as the labor room team is aware of these changed guidelines. And we need to make sure that the 2 ARV drugs, syrup nevirapine and syrup zidovudine, are available in your center. It's important because this is a very important change in guideline. We need to ensure that everybody, not only in the ART center, but also the birthing place, the labor room, and the obstetrics team and the PPT-CT counselors are aware of these. Let us look at the new guidelines. As per the current guidelines, we divide the infants, the HIV exposed infants, into 2 groups. The low-risk infants and the high-risk infants. Low-risk infants are those whose mothers, who are born to mothers with a suppressed plasma viral load, that is load of less than 1,000 copies per ml, assessed after 32 weeks of pregnancy. So what we are saying is, every pregnant woman, every HIV-infected pregnant woman must undergo a viral load testing after 32 weeks of pregnancy. And if a viral load is suppressed, such a baby can be considered as a low-risk infant. Such a baby needs to be given only 1 drug for ARV prophylaxis while the maternal ART will continue. So mother will continue to take her ART throughout her pregnancy, her labor, her lactation period, and for her life. But in addition, the baby will get syrup nevirapine. And this syrup nevirapine will be continued from birth till 6 weeks of age, regardless of infant feeding. There are certain situations in which syrup zidovudine would need to be given. That is where nevirapine is not effective. This includes infants born to women with confirmed HIV-2 or HIV-1 and HIV-2 combined infection. Infants born to mothers who have received a single dose nevirapine during earlier pregnancy, because in such a situation, there is a chance of nevirapine resistance. And also infants born to mothers who are on PI-based ART regimen due to treatment failure. In such situations, one would prefer to give syrup zidovudine rather than syrup nevirapine. So this is how one manages low-risk infants. The other group of infants is high risk, and this includes all the other infants apart from those whose mothers are suppressed virologically after 32 weeks of pregnancy. So high risk infants include infants born to HIV positive mother who are not started on ART, or who have not undergone a viral load testing after 32 weeks of pregnancy, or they have undergone a viral load testing, but the viral loads are not suppressed at a time beyond 32 weeks of pregnancy. And finally, the mother who is newly diagnosed with HIV during labor or post-delivery. All these are the situations which are high risk for HIV infection transmission from the mother to the baby, and therefore we recommend giving a dual prophylaxis of nevirapine and zidovudine both. So the duration depends upon the type of infant feeding opted for. If the infant is going to be on exclusive breastfeeding, then this dual prophylaxis is indicated for first 12 weeks of life. But if the infant is being offered exclusive replacement feeding, then we can give it only for 6 weeks. So this is a very important new guideline, which we must ensure that not only our staff is aware of this, we are able to carry it out in an appropriate manner. Next slide, please. So I think I can skip this. This slide gives you the dose of nevirapine and zidovudine, and this can be displayed in the birthing place, and it can be given accordingly. You can see these are weight band based doses, and these can be followed as per the age and the weight of the child. Next slide, please. Next slide, please. This is the dose of zidovudine. Next, please. So just to reiterate, infants with low risk of HIV transmission, whatever be their mode of feeding, the duration of ARV prophylaxis is 6 weeks and it is a single drug. Infants with high risk for HIV transmission will require 2 drugs that will be given for 6 weeks in case of exclusive replacement feeding and 12 weeks in case of exclusive breastfeeding. Next, please. And let's talk about other aspects of care of HIV exposed infants. Next slide, please. This is a national immunization schedule, and the schedule remains valid for children who are HIV exposed. So exactly the same schedule we would follow in HIV exposed infants. Remember, these children, when they are born, they are not immune compromised at birth. Therefore, but as they get older, if they are infected very rapidly, a lot of them will develop immunodeficiency. And then not only they become more vulnerable to illnesses, their response to vaccines also goes down because their body is incapable of mounting a good immune response. Therefore, it is important that we give all routine immunization to children with HIV who are HIV exposed well on time. Let us not delay it so that we can optimally protect these infants. And this is a national schedule. Please follow the national schedule, which includes giving the vaccines mentioned here. I don't need to go in the details. This schedule is available everywhere and being given in the country. Now, of course, rotavirus vaccine has been introduced throughout the country, and so has pentavalent vaccine also. The pneumococcal conjugate vaccine is being introduced in the country in a phased manner as of now, and will be available in some centers, in others it will be made available over time. Let us follow exactly the same schedule as being given. The only problems that we should keep in mind are, supposing child comes to us late and is severely immunocompromised, we should not give live attenuated vaccines to these children. Now, which basically means measles or measles containing vaccine should be avoided in children who are in a severely immune compromised state. That is, their CD4 percentage is less than 15%. In such a situation, we should avoid giving measles or measles containing vaccine for the risk of a disseminated disease. Please make sure that the other vaccines are given. There are 2 kinds of JE vaccines in our country. Both live attenuated and killed vaccines are available. And remember, JE vaccine is not being given in the entire country. It is only being given in certain states where Japanese encephalitis infection is prevalent, which includes UP and Bihar, Northeast, and some other states of Chhattisgarh, etc. So wherever J is being given, make sure if it's a killed vaccine, it can be given to all children. The live attenuated vaccine can only be given to the children who have been immune reconstituted after giving ART. not in an immune compromised state. Next slide, please. So I think I've already talked about this. Just remember, all inactivated vaccines can be administered safely, and we should administer it to them. Next slide, please. So BCG, if not given at birth, should be delayed until ART has been started and the infant is confirmed to be immunologically stable. These are all live vaccines. Measles vaccine, I've already said, should not be given to immune compromised children. Rotavirus vaccine, we are giving it at 6, 10, and 14 weeks, and it is recommended for use in HIV exposed infants due to their vulnerability to diarrhea. But if a child is known to have severe immunodeficiencies, it should be avoided at that time. And when we are giving hepatitis B vaccine, especially if we're giving it late, it's a good idea to check for seroconversion because some of these children may not respond very well, and give booster as required. Vitamin A should, of course, be given as per the national immunization schedule. Next slide, please. There's some vaccines which are not currently available through the national schedule. These are the optional vaccines. So there is a inactivated hepatitis A vaccine, inactivated influenza vaccine, varicella vaccine, these meningococcal conjugate vaccine, HPV vaccine. These are available and these are not yet part of the program. And it's if wherever feasible, it's a good idea to administer it to them. Next slide, please. So somebody asked a question about rabies vaccine. I can give a general comment. Rabies vaccine is not a live attenuated vaccine. We don't give rabies vaccine as a preventive vaccine. We give rabies vaccine as a post-exposure prophylaxis. So if somebody has been exposed to the risk of rabies, I think that risk is far higher than a hypothetical risk of a problem with vaccine. And this is not a live attenuated vaccine. These are cell culture grown vaccines. So it should be okay to give rabies vaccine to a person who needs it for post-exposure prophylaxis. So next slide, please. Growth and development. Okay, so this slide shows the development. Remember, HIV exposed infants, because of their adverse circumstances, may have a higher risk for developmental delay. And if such a HIV exposed child is HIV infected, the chances of developmental delay become more. In fact, screening for development and picking up early developmental delay may help us even detect, suspect HIV infection clinically. And if you pick it up early, we can offer them stimulation and help them. One, we can try and find the cause why the child is delayed. Is it HIV or there is some other co-infection or comorbidity that the child is having? And early stimulation can also help these children. So this chart is a very simple chart. It is there in your guidelines. It gives the age of the child in the on the x-axis in the bottom. And on top of that age line, it gives the various milestones. And the red line shows the earlier and the latest limit by which such a milestone should be achieved. So it's a very easy way to look at it. For example, if we look at holds head steady, we see a line that from the age of 2 months to 5 months. You can see the red line beginning at 2 months, going on till 5 months, still holds head steady, which means a child who is more than 5 months and is still not able to achieve a head control can be considered to have developmental delay. So likewise, one can look at all these important milestones and see if the child is having developmental delay. If there is a developmental delay, it will be good to have the child evaluated by a pediatrician. Next slide, please. This is a slide showing the growth chart. And this is something we would really request all of you to do, because a well-maintained growth chart is a summary indicator of a child's health. If we keep on, all we want you to do it during the first year. This is HIV exposed child. Every time the child comes to you for immunization visit, 6, 10, 14 weeks. After that, the child may come at 9 months. And in between, every time the child is coming, remember, you're calling him for testing also. So we'll be talking more about the HIV EID. When the child comes to you for EID, on every occasion that you have, please take the child's weight and plot it serially. And what we expect is a growth chart to yield a curve, if we do it over time, to yield a curve parallel to the lines that you see here, and in between the +2 and the -2 z-score line. So if the child's serial growth is parallel to these lines and remains between +2 to -2, the child is doing well. But if the child shows growth faltering, that is a fall, the growth curve flattened, or it becomes shows a downward slope, that indicates that the child is losing weight, and this is a high risk situation. A child who is not maintaining his growth chart, growth trajectory, must definitely be evaluated by a pediatrician. But it is very important for the ART center staff to maintain a growth chart. If you don't maintain a growth chart, you will miss the early growth faltering, which you can pick up only by maintaining a growth chart. You will only pick up a child when he becomes grossly malnourished. We should not do that. We should be able to pick him up before he becomes grossly malnourished, just when early growth faltering happens. So we should pick up early growth faltering, evaluate the child. Why is he having growth faltering? Is there a nutritional problem? Is it HIV? Or is it that he's got other co-infections? We should evaluate the child and find the appropriate cause and treat it. Next slide, please. It would be great if you can measure the length and plot also. Weight is absolutely 100% essential, but if you can monitor length, that would be wonderful, because a lot of HIV infected children can have stunting. So, but if we give them optimal management, if we give them ART from beginning, we will be able to optimize their growth. So again, if they are growing well, if their height is growing, that overall indicates a child's health is doing well. Faltering in height also indicates presence of a chronic systemic disease or new onset disease. So again, a very good sensitive indicator of child's overall health. Must request all the ART centers to procure stadiometers, to procure infantometers, and monitor the child's growths. Next slide, please. Next, please. These are all charts available in your book as annexes. Now we'll come to the next important part. That's the diagnosis of HIV infection in infants and children. Next slide, please. So EID is needed for two groups of children. One, those who are HIV exposed and we are following them up. And secondly, infants who are sick with clinical features suggestive of HIV, but with unknown HIV exposure. So we are not sure if sometimes they come to us with sickness. So in such a situation, we would actually first check the mother for her status. If mother is HIV positive, and then we can go ahead and check the child. Next slide, please. So this is a little busy slide, but I will try and take you through the algorithm. I think most of you are familiar with the algorithm, which has not really changed much. So for early infant diagnosis, what is the basic principle that we are talking about? We are saying that the baby, the HIV exposed infant, has passively transmitted antibodies against HIV from the mother. Now these antibodies are going to test positive if we do the standard HIV test, that is the ELISA, on the infant. The standard HIV test is what we use for diagnosing HIV infection in adults and children beyond 18 years. They check the antibodies to HIV in the blood of the patient. Now, HIV exposed infants for a variable period of time have antibodies from the mother, which came to them through at the time of pregnancy itself. Through the placenta, the baby gets the antibodies. Now, if we do the same ELISA test in the baby and the baby tests positive, it does not always mean that the baby is infected. It may also mean that these are the antibodies that were transmitted from the mother that are testing positive. Therefore, we cannot use ELISA for diagnosing HIV infection in an infant. What we need to do is something known as a PCR test. PCR test tests something known as antigen. So that is the actual part of the virus in the child. And that does not get transmitted to the baby from the mother. If it tests positive, then it indicates that the virus is actually there in the body of the child. Therefore, the test that we use for confirming HIV infection in HIV exposed infants and children less than 18 months is the HIV-1 PCR test. How do we do this? We do the first test when the child comes to us at the age of 6 weeks. So any HIV exposed infant, we follow a universal advisory, which I will show you in the next slide. You determine the age of the child. If the child is between 6 weeks to less than 6 months, we collect the blood for dry blood spot and send it for testing. This DBS is tested for HIV-1 PCR. If HIV is detected, we collect and send another DBS. Okay. And if this second DBS is also positive, we label the child as HIV infected, and he is then attached to the ART center for the routine HIV care. If in the DBS, HIV is not detected, okay, so such a baby, it means the child has not got infection as of now. So this HIV exposed infant is closely monitored for growth, development, and appearance of any signs of HIV, and we follow him up. Anytime that this child develops symptoms suggestive of HIV infection, we can repeat this test. Can I go to the next slide? So just focus on the left side of the chart. So we had found that if HIV-1 is detected, baby is linked to the ART center, as you can see. If HIV-1, if in the first test the HIV was detected and we have repeated the test and second test is not detected, then there is a discordance. That is, the first test came positive, second one came negative, then the laboratory may require another test, and that third test will confirm finally whether the status of the child is detected or not detected. If HIV-1 is detected, then we follow something known as Advisory 2. But before that, what is Advisory 1? Advisory 1 is for all HIV exposed infants, where at 6 weeks, we would start cotrimoxazole prophylaxis and just generally encourage exclusive breastfeeding. And if age is more than 6 months, complementary feeding starting would be advised. If the baby is HIV infected, then we will continue with cotrimoxazole till 5 years of age. If there are any OIs, we will manage those. And such a baby, as per the current guidelines, will be started on triple drug ART, which is PI based. And we will continue with breastfeeding and initiate complementary feeding as already explained. And we will test for HIV antibodies using all 3 serological tests at 18 months. And the last test we do 3 months after stopping breastfeeding. But in a child who is already infected, we don't need to do another test. We will do it at 18 months and leave him there. If the child was not infected during the first testing, we will continue to follow this child. Can we go back to the previous slide, please? So now let us look again and follow this algorithm B. So this is what we have done if the baby was 6 weeks to 6 months of age. What happens once the child is 6 months old or more? In such a child, we will do another test. So first test done at 6 weeks, second one done at 6 months or beyond. Here, what we do is first we do a serology. At the same time, we also take a sample for DBS. If the child is antibody negative for all 3 serological tests, the baby is not infected at that stage and he does not need a PCR test. But we will follow up this child still. So baby is probably not infected, but is at risk. And therefore, we have to schedule a follow-up visit for this child. Okay. If he, just go back. If he was reactive on antibody, then such a baby, we will send the DBS test. We had already taken the DBS test at the time of taking the serology sample. If he tests positive on antibodies, we are not sure that these antibodies are acquired from the mother, or is it because the child is antibody or these are his own antibodies. So we will do the DBS, and based on the result of DBS, we will decide whether the child is infected or not. Next slide, please. So a child who is negative at the 6-week test and negative at the 6-month test, we will follow the advisory 3. That is, we will repeat the testing at 6 months. Beyond 6 months, we'll do it at 12 months and 3 months and 12 months, 18 months, or 3 months after cessation of breastfeeding, whichever is earlier. So we will do it at 3 or 6 months, 12 months. At any time, if a baby develops signs and symptoms of HIV infection, we will do the test at that time. We'll continue cotrimmoxazole till proven negative by all 3 antibody tests at 18 months or later. Remember, if the child is not being breastfed, we will do the last test at 18 months. If the child is still being breastfed because it's still kind of exposed to the risk of acquiring infection, the last test is done 3 months after stopping breastfeeding. Next slide, please. In a child who is presenting beyond 18 months of age, the testing is like we do for adults. So if the child comes to us at 18 months, we will see whether he has undergone previous PCRs. If he had gone previous PCRs and he was diagnosed to be HIV infected earlier, we will just do HIV antibody testing for a definite diagnosis using all 3 serological tests. If previously his HIV was not detected by PCR on the previous test, we will do the 18-month testing for using the 3 antibodies test for a definitive diagnosis. Next slide, please. I think this is a very complicated slide. I will not go into managing the discordance. Let us, I think, skip the discordance. I will advise the readers to read about it in the guidelines. But I will say that our last testing is done either at 18 months or 3 months after stopping breastfeeding, where we will do all 3 serology tests. A child who's been diagnosed to have HIV infection through the PCR test done earlier should continue to receive ART. However, if such a child tests negative on testing by antibodies at 18 months, this child requires a detailed evaluation. Please do not stop ART for such a child if you have already started, but repeat detailed testing is needed. But if a child has already been started on ART and also tests positive for by antibodies, the child's confirmed status of HIV infection is kind of reconfirmed and we continue with the ART. Next slide, please. We also have something known as the presumptive testing, presumptive HIV diagnosis. This means a diagnosis of severe HIV disease in a child made in a situation where virological testing is either not available immediately or we have done the test and the report is pending. Sometimes we are faced with this situation. For example, we have a baby who's symptomatic. And what we mean by symptomatic, he has 2 or more of the following, like oral thrush, severe pneumonia, severe sepsis, or he has any of the AIDS indicator conditions, which would basically mean, say, disseminated tuberculosis, which means severe malnutrition, may mean disseminated cryptococcosis. So any of, or maybe pneumocystis infection. So if we are strongly suspecting HIV in a child and the infant or the mother's HIV antibody test is positive, if the mother is positive or the baby's own HIV test is positive and is symptomatic, while awaiting the test report of DNA PCR, we can start such a baby on ART. It is important because sometimes these children are so sick and sometimes our reports, the DNA PCR report, first test, and then we do a repeat test to confirm, takes time, and a sick child may not give us that much time. So in such a situation, we make a presumptive diagnosis of severe HIV disease and start the ART and review the diagnosis once the reports become available. This is what is known as presumptive HIV diagnosis of presumptive severe HIV disease. Next slide, please. So I think we have already covered that. Next slide, please. So diagnosis of HIV infection in an infant with suggestive symptoms. For infants less than 18 months, we need to confirm. All infants with less than 18 months, we must confirm with PCR. And for infants more than 18 months, antibody testing is enough. Next slide, please. And this is the follow-up protocol of HIV exposed infants. In general, these must be followed up till at least 18 months or till we do the last test, which is 3 months after stopping breastfeeding. So we have linked the baby, HIV exposed infant for follow-up, begin the cotrimoxazole at 6 weeks of therapy, and continue as we test the baby. If the baby, the final, after the testing, after the risk period is over and the child remains HIV uninfected, we will stop cotrimoxazole. For other infants who test positive, we will continue cotrimoxazole preventive therapy for the first 5 years. This is started at 6 weeks of age. And we follow the child at birth, 6, 10, and 14 weeks for the immunization. At 6 weeks, we are also doing the early infant diagnosis. At 6 months, we are doing the second test for HIV infection. At 9 months, we are giving the measles vaccine. And so we follow up the child. 12 months is again HIV infection testing. So this is the follow-up schedule of the child as shown here. Next slide. And this slide in a comprehensive way shows all the activities that need to be followed at each visit. In a nutshell, it includes all that I have spoken about. And you will see that growth monitoring, development assessment, and counseling for infant feeding happens at every visit. So age appropriate assessment is done, and immunization is carried out as per the national schedule. Clinical assessment for any signs of HIV are also done at every national schedule, and maternal health and ART adherence is also insisted upon at every visit. And HIV testing is done as per the schedule. Next slide, please. So that is all from my side. Thank you very much. If there are any questions, I'll be happy to take.
Thank you so much, ma'am. Is it okay if we take questions at the end of the session?
Dr. Kiran, I'll not be available. I need to go. Okay. So maybe when you can post me the questions in that case.
Sure, ma'am. We'll do that. Yes.
If there's any quick question, I can answer, or else I'll let it be.
Just give me 2 minutes, ma'am. The rabies vaccine has already been answered.
Yes.
No more questions in the chat box. If there are any questions, we'll keep you posted now.
All right. Thank you.
Thank you so much, ma'am. I now request Sanjeeva sir to please continue the session.
Good afternoon, everybody. I would like to thank the organizers for giving me this opportunity to share my thoughts on this chapter 3.2. And after that very good session from Madam, this is another important session where a lot of things we usually practice in our day-to-day activity in our ART center. So this is management of newly diagnosed children with HIV infection, which also includes initiation of ERT. Next slide, please. Okay, so before we initiate ERT to children or even for adult, the first step is to determine the clinical and immunological staging. You have to look at a child as a whole. What are the problems this child is having? What is the status of the child? This is very important to tailor-made or to customize the care for the child, number one, and also to look at the response. Once you start ERT, you need to look at the response, how the child is responding to your antiretroviral therapy. So for these things, it is very important to have a holistic care or a holistic approach towards a child with HIV infection. Okay, the important component of this assessment of any child who is recently diagnosed with HIV infection include number one, growth assessment, which was briefly touched upon in the previous session by Madam, and it will also be extensively discussed in another session on nutritional care. The most important aspect in this session will be on clinical assessment, which includes history and physical examination. Developmental assessment again has been touched in the previous session. Lab assessment and psychosocial or psychological assessment. Yeah, so in the clinical assessment, this is, been patterned in the same way as we use in our IMNCI, where you ask and look and feel for. So you should ask for 4S screening for tuberculosis, 4 symptom screening. We all know what are the 4 symptom screening. One is a fever, cough, history of contact, and weight loss or not gaining weight in children. So these are 4 symptoms you need to screen, which will screen for tuberculosis. This has to be done with every visit. Definitely, yes, in the baseline, as well as every visit we need to do that. And the key component in pediatric assessment is age appropriate developmental milestones. We are going to discuss that in detail. And behavioral abnormality, especially when the children are adolescent and older children, we need to look for behavioral problems and behavioral abnormality. And because nowadays a lot of thirst on mental health, so we need to look at that. Relevant medical documents like immunization status, past history of any OIs, all those things to be seen, and assess immunization status, and look for any signs of anemia, edema, because edema gives an indication on malnutrition, especially kwashiorkor. So severe malnutrition, severe acute malnutrition comes with edema. You need to look for edema. There are other causes for edema also, but this is the most common cause for edema in children. And nutritional deficiency like angular cheilitis, ball tongue, platinacea, dermatosis. So all these things you need to look for nutritional deficiency, and jaundice. Again, you should look for fever, respiratory distress, decrease in activity, or altered sensorium. Altered sensorium comes in a different way in children. Most of the time, child will be either irritable or dull in the sensorium. You need to look for that, and do a good oral examination, where oral cavity examination, where you need to look for oral thrush and parotid enlargement. It can be painless. Bilateral parotid enlargement. It just gives you an idea about what stage the child is having, what clinical stage the child is in, and look for herpes, current herpes, or a past history of herpes infection, especially herpes zoster, which is quite common in children with HIV infection. And clubbing gives a lot of clue. It gives clue about tuberculosis, bronchiectasis, lip, and other things, and lymphadenopathy, and HIV dermatitis, as well as hepatosplenomegaly. Next slide, please. And when we are looking at developmental assessment, this is very important. You have to ask for, is there any developmental skills which was previously acquired by the child, now it is lost. For example, a child who was sitting well, or a child was walking, a child was running around, walking around, speaking, now stop doing all those things. Child who was sitting now can't able to sit, who had a good neck control, neck holding, now the child is not holding his neck. So this is an loss of previously acquired developmental milestone. This is very dangerous. It's a very alarming sign. It's called Neuro Regression, which is a mark of HIV progression. We need to be very careful when assessing this. Should also ask for any issues with the vision, especially fixing or following of an object, and hearing loss, and low muscle tone, or a floppiness of the muscle. So we call it as hypotonia. No speech by around 18 months of age, especially when child is not even trying to communicate with any other means like gesturing, pointing. So it can be a mark of, again, HIV associated encephalopathy. Asymmetry of movement or hand preference, early hand preference. Usually we don't expect a child to show the hand preference before 18 months. If any child, we can able to identify whether the child is right-handed or left-handed before 18 months, then that means the other side is weaker. So there may be a hemiparesis or congenital hemiparesis. So we need to look for that. And persistent toe walking. We would have seen children walking on toes. So that means there is a tight Achilles tendon. So that's again a sign of CNS problem or a developmental problem. And most important is head circumference. We need to measure head circumference, especially in the first 3 years of life. You should measure that, and you should plot it on the curve. If it is less than 3 standard deviation, it's called microcephaly. If it is more than 3 standard deviation, then it's called macrocephaly. Both are important. in the context of developmental assessment. Macrocephaly can be due to hydrocephalus or any other conditions. Microcephaly is definitely, it's a very severe condition. We need to be careful about that. Acquired microcephaly is one of the feature of HIV encephalopathy. So we need to identify that. And if any clinician who is not very sure about any aspect of assessment, but thinks that development is disordered should be referred to pediatrician for a proper assessment. So what are the red flag signs? If a child is not sitting at around 12 months of age, sitting unsupported, then there's a very red flag sign. Similarly, a child is not able to walk up to even by around 18 months of age. You need to look for creatine kinase, serum creatine kinase levels, CPK level, which may be elevated. Again, it's an indication of some other diseases. So similarly, walking other than tiptoe, or cannot able to run by 2.5 years. So these are again signs of motor weakness. Child cannot able to hold object placed in the hand by around 5 months, which is corrected by the gestational age, and not able to reach for an object by around 12 months. You look at any normal child, if you dangle a keychain in front of the child, by around 5 months, child should be able to come and pick it up with both the hands. That's called reaching of an object. If this is not developed even by around 6 months of life, this is again a red flag sign. So we previously also, it was shown that there is this Triventrum developmental chart. Next slide, please. Yeah, so this chart will help us in monitoring the development of the child. Madam has discussed this in detail. So just you put a scale vertically for the corresponding the child's age, and the bar which are completed before that scale should the child should have achieved those things. Those who are on the left side still has got time to those which is on the right side, there is still time to achieve. So this is how this whole Triventrum developmental screening chart works. So this is a very useful tool to monitor development and to identify the red flag signs in children while assessing for development. Next slide, please. Yeah. Now, the most important is laboratory assessment. So we need to do few basic investigation. We all know about this. Most of us are already practicing HIV care in our clinical practice. This is just to recap what we are doing and re-emphasizing what we need to do. So definitely all children should have one complete hemogram, baseline, urine for routine and microscopic examination. Fasting blood sugar will be a problem in the clinical setup. So random blood sugar is important. If there is any abnormal random blood sugar, then we can definitely go ahead and do the fasting and postprandial blood sugars. Blood urea and serum creatinine is very important when you are planning to start an tenofovir based regimen. Serum bilirubin and liver enzymes, SGPT, especially ALT, is very important. Many of the drugs which we use as antiretroviral therapy or other medications like your anti-tubercular drugs are hepatotoxic. So it will help us in monitoring these toxicity also. And VDRL, especially in young child, it's very important, and even in adolescent if they are sexually active. CD4 count and CD4 percentage, HBsAg and HCV if it is available. Chest X-ray PA view to rule out any tuberculosis or any pneumonia, deep-seated pneumonias and other pulmonary conditions. In adolescent, if required, pregnancy test should be ordered. And in children who are coming from endemic area for leishmaniasis, you have to do this RK39 strip test to either confirm or rule out leishmaniasis, especially those who are coming from Bihar, Eastern UP, Jharkhand and West Bengal. Some of the additional tests at the baseline, which is symptom directed depending on the physician's treating physician's decision, can be symptom or sign directed to rule out opportunistic infection like tuberculosis, maybe sputum or gastric lavage in children, and specimen for NAT, TB-NAT, and other required investigation. Maybe we have to do a complete liver function test, especially when you are planning to start the child on anti-tubercular treatment, and for patient with hepatitis B and hepatitis C co-infection, to look at the status of the liver. Similarly, lipid profile, if it is available when you are planning to start PI based ART regimen, and ultrasound abdomen when you are looking at hepatosplenomegaly or any other organomegalies, if it is available. But most important is you need to remember, if these tests are not available or not feasible in any situation, this should not be the barrier to start the ART. You should not delay ART pending these investigation. These tests are not available. Whatever tests are available, you do that and start appropriate ART. So all above investigation other than CD4 should be done with the healthcare facility where the center is located, with the support from the state health department. NACO is not going to support these investigation apart from CD4 count. Next slide, please. Yeah. Then once you have done CD4 count, you need to look at, you need to stage the child immunologically. This is WHO classification for immunological classification. We all know children less than 5 years, usually they have very high CD4 counts, but still they can be severely immunosuppressed. So absolute CD4 count is not a good marker of immunosuppression in children less than 5 years. So in such scenario, we are considering the CD4 percentage. CD4 percentage is the percentage of CD4 cells with respect to total lymphocyte count. Whereas for children above 5 years, we can take the absolute CD4 count just like what we use in adults. So in children less than 11 months, if CD4 percentage of less than 25% is considered as severe immunosuppression. Similarly, less than 20% in children between 12 months to 35 months is considered severe immunosuppression. And children between 36 to 59 months, any CD4 percentage of less than 15% is considered as severe immunosuppression. Next slide, please. And this will also help us in monitoring the response to therapy and also initiating appropriate prophylaxis in children with HIV infection. Now, the next important step is initiating the pre-ART care. So when we talk about pre-ART care, this was a major component when before this advent of test and treat policy or treat all policy. Because there used to be a long period of pre-ART status, and then you need to provide care. You need to identify children who are going in for immunosuppression eligible to start ART. But now with the test and treat policy, many people have started questioning what is the role of this pre-ART care. But there is a role for pre-ART care, though the period of pre-ART is very short because of initiation of ART to all the children. But this term is very important. It is still relevant even in the current context of treat all policy, because whatever the activities listed under this head would still need to be carried out or at least initiated before starting antiretroviral therapy, and should be continued along the side of antiretroviral therapy. So this is very important to know the pre-ART care and to give the pre-ART care for children before initiating antiretroviral therapy. Next slide, please. Now, you may encounter many clinical conditions in children when you diagnose HIV infection. For example, these children usually now with mother to child transmission, the rate has become so low. We usually see children who are symptomatic and who are coming later in the age group. So invariably they present with undiagnosed active infection with fever. So in such scenario, before you initiate ART, diagnose the cause for fever and start ART after treatment of that condition and when the child is stable. Similarly, tuberculosis, ART should be initiated as soon as possible within 2 weeks of initiating anti-tubercular treatment, regardless of CD4 count and age of the child, except when the child has got meningitis. In meningitis, you need to wait for some more days till the child is stabilized. Pneumocystic carrier pneumonia, treat PCP first and then start antiretroviral therapy when the PCP treatment is completed. Usually it takes 3 weeks, 21 days to complete the treatment. As soon as you complete the treatment, continue the secondary prophylaxis for PCP and then initiate ERT. Any child with invasive fungal infection like esophageal candidiasis, cryptococcal meningitis, histoplasma, penicillinosis, so then you have to treat these conditions first and then start ERT as soon as the patient can swallow comfortably. Cryptococcal meningitis, so treat cryptococcal meningitis first. Start antiretroviral therapy when the patient is stabilized or OI treatment is completed. Usually cryptococcal meningitis, the treatment completion will take some more time. Once the child is stabilized after 2 weeks, then you can start ERT. Bacterial pneumonia, so the treatment is short, so you can complete the treatment and you can, after completion of treatment, you can start antiretroviral therapy. Similarly, malaria also, treat malaria first, then start ERT. Any drug reaction, please don't start antiretroviral therapy, especially when the child is going through that acute phase, because number one, it may aggravate the situation, or you may not be able to identify if there is a concurrent drug reaction to the same, to the antiretroviral drugs also. Similarly, if the child has got an acute diarrhea, diagnose and treat first. If there is a chronic diarrhea, stabilize the child, start the nutritional rehabilitation, then start ART. Non-severe anemia, start ART if there are no other cause of anemia are found. So most of the time, HIV itself is a cause of anemia. And in fact, in our clinical practice, we have seen many children coming with autoimmune hemolytic anemia also. You need to identify and treat them, and you can start parallelly also antiretroviral therapy. Remember, antiretroviral therapy itself is a big, it's a specific treatment in some of these scenarios. But you should always remember that Judovidin should not be used when the hemoglobin is less than 9 grams %. Next slide, please. So skin conditions, these are no bar to start ART. Similarly, if you're suspecting MAC infection, cryptosporidium or microsporiosis, the specific treatment for these conditions itself is antiretroviral therapy. So it will resolve these problems. So start that. CMV, start treating CMV first, and then ART after induction phase of treatment is over. Remember, there may be an iris for CMV. If you start ART early, you should always keep a watch when you are treating CMV as well as antiretroviral therapy. And then toxoplasma, start after 6 weeks of treatment and when the patient is stabilized. Severe acute malnutrition should be started as soon as possible after stabilization of metabolic complication and sepsis. Usually it will take around 7 days. Next slide, please. So another important component of evaluation of adolescent living with HIV, because we are going to see many children who will be diagnosed HIV for the first time during adolescent phase. They will have a lot of issues. There will be a lot of questions. You need to identify these children. Next slide, please. So you have to evaluate them. There is a step-by-step guidance and for the comprehensive assessment of adolescent living with HIV. This whole chapter was written by Anju madam. So it's very beautifully written. You can go through this. So there are few components here. You need to ask where these adolescents are living. What are the recent changes in their home situation, and how do they perceive their home situation? If they are not living in the house, if they are living in any organization or institutions, you need to ask about their adjustment and coping mechanism there. Similarly, education, are they still studying? Are they doing some work? What is their relationship with their teachers, colleagues and employers? And what do they do in their breaks? Do they have any addictions or something? You need to ask those things. What about their eating behavior? How many meals they have? How do they eat? And what do they feel about their body image? And activity, what activities they are involved other than study or work? Do they have any recreational activities during their free time? Do they spend some time with the family members and friends? And drugs, about use of tobacco, alcohol or substance? Do they inject any substance? And you need to explore those things also. How many times they use, with whom and where? So these are some of the risk factors they will be going through. Next slide, please. You should ask for sexuality. What knowledge do they have about sexual and reproductive health? Do they have any questions regarding this? Are they sexually active? If yes, are they taking adequate steps to avoid sexual and reproductive health problems? And what is the sexual orientation? Safety, do they feel safe at home, in the community, or in the workplace? Any stigma, discrimination? If they are feeling unsafe, what makes them to feel so? So you need to ask that. And you should also ask for suicide or depression, because many children are depressed. We may not be able to, it may not be very obvious clinically. So if you don't identify and do the corrective measures, you may end up losing those adolescents. So ask about the sleep habit. And do you feel that they are unduly tired, they are eating well? What about their emotions, mental health? And do they have any suicidal thought, anytime attempt? Don't prompt these questions, but you need to be very subtle in asking these questions. Very important. If there are any red flag signs, please refer them to appropriate authorities so that remedial measures will be taken. Next slide, please. So the another important component of this session is antiretroviral therapy. What drug to use, when to initiate, and how to use. Next slide, please. So ERT should be initiated in all children and adolescents who are living with HIV infection, regardless of age, CD4 count, and WHO clinical staging. So you confirm HIV infection, either you do serologic through serological test, or in children less than 18 months through virological test. Once you do that, then you treat and stabilize acute conditions like opportunistic infections, malnutritions, and etc. And then do the baseline investigation, which includes CD4 count, and initiate appropriate first-line antiretroviral therapy. Again, regardless of WHO clinical staging or immunological staging. Next slide, please. So what are the first-line ART regimen? It depends on the child's age and body weight. Children less than 6 years and body weight less than 20 kg, the recommended regimen is abacavir, lamivudine, and ritonavir-boosted lopinavir. Similarly, children between 6 to 10 years of age and body weight between 20 to 30 kgs, the recommended regimen is abacavir, lamivudine, and dolutegravir. For children more than 10 years and body weight of more than 30 kg, to harmonize with the adult regimen, tenofovir, lamivudine, and dolutegravir is the recommended regimen, that is TLD. So any infant or child initiated on any regimen must be based on body weight. So there is a detailed dosing chart is given. It is there in your guidelines also. Please refer to that. Every time whenever you initiate a ART, or whenever a child comes for follow-up also, you should check the dosage for that weight, whether it is appropriate. If it is not appropriate, please optimize the dosage. We have seen one of the most common cause for early treatment failure is suboptimal dose. People would have started on antiretroviral therapy based on baseline weight. Child would have grown over a period of time, and that dosage regimen was not changed. So the child would be taking the suboptimal dose over a period of time, maybe around 1 year or so. Then child will come with increased viral load, so suboptimal response. So this is one of the most common cause for early treatment failure. So you should always keep a watch on that. So on every visit, check body weight of the infant or the child before writing prescription. Even though the drug regimen remains same, the drug dosage have to be modified according to the change in the body weight. Next slide, please. So these are dosing chart which is been given in the in the guideline book. There are some drugs which are not available in our national program currently. We may get it in future. For example, DTG 5 milligram dispersible tablet and 10 milligram score dispersible tablet are not available in the current program. So 10 milligram tablet DTG is going to be introduced into the program in near future. So with keeping that in mind, this whole dosing chart has been designed. So whatever is applicable to us, it can be used. It's a very detailed dosing chart, which also includes for super boosting of protease inhibitors, which we are going to discuss when we are going to do that, the scenarios where we are going to use the super boosting. And next slide, please. So here also there are few drugs which are not available. For example, darunavir, 400 mg, 800 mg, these drugs are not available. Just for the completion sake, these are provided. And 100 mg, 75 mg, 400 mg darunavir is not available. Next slide, please. So Again, this is a dosing chart where you are using ritonavir for super boosting, especially when you are using lopinavir based regimen. So you have to add extra ritonavir tablet, 50 mg tablet in few situations. If you don't have 50 mg tablet, you can use the half tablet of a 100 mg tablet. So this will super boost the ritonavir boosted lopinavir. This is used when you are using the rifampicin, concurrently using rifampicin based anti-tubercular regimen. We are going to discuss that next. Next slide, please. Raltegravir suspension is not available. I am skipping these two slides. Next slide, please. Yeah. So in the nutshell, what is the recommendation? Choice of regimen: confirm HIV infection, treat and stabilize acute opportunistic infection. Baseline investigations are to be done, which includes CD4 also. Prepare the family for lifelong ERT. This is very important. Then look at the body weight and age of the child, less than 6 years, less than 20 kgs. The regimen of choice is abacavir, lamivudine, and ritonavir boosted lopinavir. Children between 6 to 10 years and body weight of 10 to 13 kgs. The regimen is abacavir, lamivudine, and daltegravir. Children between more than 10 years and more than 30 kgs, harmonized with the adult regimen, tenofovir, lamivudine, and daltegravir. Next slide, please. So in some special situations like tuberculosis, next slide, please. Yeah, so you have to modify ERT regimen in children who are already receiving ERT, as well as now diagnosed with TB co-infection and rifampicin based ATT is started. Suppose if the child is on DTG based regimen, you have to double the dose of DTG. Instead of giving OD dose, you need to make it twice daily, and this should be continued 2 weeks after the last dose of rifampicin is reduced. Similarly, ritonavir boosted lopinavir regimen. Here you need to super boost the lopinavir with the additional ritonavir in the ratio of 1:1. So this again should be continued 2 weeks after stopping rifampicin based regimen. Efavirenz based regimen, no modification is required. If the child is on DTG and ritonavir boosted lopinavir regimen, you need to double the dose of DTG as well as super boost the lopinavir. And again, this should be continued 2 weeks after stopping the rifampicin based regimen. Next slide, please. So timing of initiation of ERT, especially when you are newly diagnosed HIV as well as tubercular infection. In that scenario, initiate antiretroviral, anti-tubercular treatment first, and then ERT should be initiated as soon as possible within 2 weeks of initiating TB, regardless of CD4 count among children living with HIV. Except in a situation where TB, you have diagnosed with TB meningitis. So in that scenario, ERT should be delayed at least 4 weeks, but we should be initiated before 8 weeks after treatment of TB meningitis. You should also consider using adjuvant corticosteroid therapy when you are giving TB meningitis, when you are treating a child with TB meningitis. Next slide, please. So TB co-infection, the regimen is just to summarize: weight less than 20 kgs and age less than 6 years. The regimen will be abacavir, lamivudine, and ritonavir boosted lopinavir with super boosting of with additional ritonavir twice daily, and between 20 to 30 kgs and age between 6 to 10 years, abacavir, lamivudine, and daltegravir twice daily regimen, and children above 10 years and above 30 kgs, tenofovir, lamivudine, and daltegravir twice daily daily regimen. So again, these enhanced regimen should be continued for 2 weeks after the last dose of rifampicin is received. Next slide, please. Thank you.
Thank you so much, sir. Any questions? Kiran, can we please unmute the participants?
Done, ma'am.
Participants are now requested to please unmute their mics if they have any questions.
Hello.
Hello.
Hello, ma'am.
Yes,
Yeah.
yes, sir.
Yes, ma'am. Dr. Kunal from YCM ERT Center, ma'am. Hello.
Yes, sir. Please go ahead.
Yes, sir. Ma'am, the question is, I have a newly diagnosed CLHIV. It's a male baby. Hello.
Yeah,
So
please.
we can hear you.
Yes, sir. Yes, sir. So he's 3 years old, sir. His CD4 count is 143, sir. Weight
Okay.
is 8 kg.
Okay.
patient lives in a tribal area, sir. उसको track करके हमने यहाँ पे लाया था center में. So we have done the basic investigation over here, this side. Sir, जब वो यहाँ पे आया था first time, the first visit, his HB was 8. Then his creatinine was 0.6, and his SGOT and HGPT were like fine, sir. But after 15 days के बाद patient घर पे चला गया, sir, because उसको GL करना था, sir, उसका स्पूटम का. तो फिर यहाँ पे बेड अवेलेबल नहीं था हमारे यहाँ पे हॉस्पिटल में, तो फिर सजेस्ट किया था कि कल आ जाए. बट पेशेंट वाज ये था, मतलब ही कैन नॉट कम ना, सो ही केम आफ्टर 15 डेज. तो फिर हमने उसका एडमिट करके सर उसका स्पूटम किया जीएल लेके. सो स्पूटम सीबीनेट किया तो नो एफबी सीन करके आया. फिर उसके बाद सर उसका माला न्यूट्रिशन तो है ही सर. बेबी को थ्रश भी था, प्लस सीवियर वीकनेस भी था, और प्लस थोड़ा सा सेंसोरियम उसका खराब भी था, सर. तो फिर सर उसको अभी 15 डेज का फॉलोअप दिया है अगेन पीडियाट्रिशियन ने कि ही शुड इंप्रूव हिज हाइड्रेशन एंड एवरीथिंग. द प्रॉब्लम इज दैट सर इसका एचजीओटी और एचजीपीटी 60 और 136 से अभी. So should we start the ERT after 15 days if the reports are normal again?
See, I think, I mean, these are individual questions. In this scenario, definitely child has got, I mean, there are issues, acute voice are there. You have reasonably ruled out tuberculosis. I can't say I can be 100% sure. Child has got definitely malnutrition, oral thrush. You stabilize the acute infection, like you treat oral thrush. You should immediately start antiretroviral therapy, because your SGOT, SGPT 136 is not a contraindication to start antiretroviral therapy. And the child should go for abacavir, lamivudine, and ritonavir boosted lopinavir ASAP.
Okay, sir. Sure, sir. Sure, sir. Ceftriaxone has been given, sir, already to the patient. Actually, we have started syrup Ceftriaxone.
Good.
Yes.
Sir, my question is, from what age or what body weight atazanavir ritonavir based regimen can be given?
I think, I mean, it's already given in the dosing chart. If you have that dosing chart, you can go through that. I mean, internationally, it is recommended any child above 6 years and 25 kgs can be given. But the problem is there are not much of experience when there is a, what do you say, when there is a concomitant tuberculosis and rifabutin is not available in pediatric formulation. So then it will be a challenge to super boost atazanavir, because super boosting atazanavir is not heard of. So that's why we try to keep it after 35 kgs and older children. For children more than 35 kgs, you can use atazanavir, where even if there is a concomitant tuberculosis, you can use rifabutin or some other drugs, which whatever you use in adult.
Okay, sir. Thank you.
So we have a question in the chat box. In case of a child having abacavir hypersensitivity, what would be the preferred ART regimen?
Yeah, in children who has got abacavir hypersensitivity, the alternate first line regimen. I think we have not covered alternate first line regimen here. That will be another session. We are going to cover that. This is just a simple first line regimen. We have not even gone to monitoring of first line regimen. The alternate first line regimen will come after you do the monitoring. So the alternate for abacavir is zidovudine. We have zidovudine still in our program. So zidovudine, lamivudine, and probably ritonavir boosted lopinavir or dalteravir, depending on the age and body weight of the child.
Any more questions from the participants? Please, you can unmute your mic. So I don't think there are any questions. Can we go ahead with the post test, please?
Yeah, from my side, fine. Thank you.
Thank you, sir. Kiran, can we have the post test, please? Participants are requested to please attempt the post-test questions. There are 5 questions in all. Please scroll through your screen, scroll through the questions and attempt all the 5 questions. We have another 3 minutes for the post-test. Participants are requested to please attempt the post-test questions. Kiran, we can end the e-poll now. Thank you. I'll quickly run through the answers for the post-test. The first question was, which of the following is not true regarding risk of HIV transmission through PTCP? The answer is risk of mother to child HIV transmission is 5 to 7% in case of 3 ARVs, that is ART, and no breastfeeding. The second question was, mark the false statement regarding mixed feeding. The false statement is, no breastfeeding should always be preferred over mixed feeding, even in continued presence of maternal ART. The third question, in which of the following cases the infant will not be considered as high-risk infant? The answer is, infants born to mothers with suppressed plasma viral load assist in any time after 32 weeks of pregnancy up to delivery. The fourth question, which of the following statements is or are not true for infants born to HIV positive mother, not on ART? Syrup lopinavir ritonavir should be used as prophylaxis from birth till 12 weeks of age in case of exclusive breastfeeding, and syrup zidovudin should be used as prophylaxis from birth till 12 weeks of age to infant born to a mother who has received single dose of nevirapine during earlier pregnancy or delivery. Which of the following is first-line ART regimens for infants and children with HIV-1 and HIV-2 infection? All the three answers are correct. First, abacavir plus lamivudine plus lopinavir ritonavir in children less than 6 years of age and body weight less than 20 kg. Tenofovir plus lamivudine plus dolutegravir, that is TLD, in children more than 10 years of age and body weight more than 30 kg. Abacavir plus lamivudine plus dolutegravir in children of age between 6 and 10 years and body weight between 20 kg and 30 kg. Kiran, can we have the feedback form, please? Thank you. Participants are now requested to please attempt the feedback questions. There are 4 questions in all. Please scroll through the questions and answer all 4. Kiran, we can end the equal now. Thank you, Anju ma'am. Thank you, Sanjeeva sir, for this informative session. Thank you, Puri sir, for the opening remarks. Thank you to all the participants for patiently listening. The next session is on 3rd August. The topic is Advanced Disease Management in CLHIV less than 5 years of age and Nutritional Care of HIV infected children. And on 8th August, the topic is Care of CLHIV post-ART initiation. We thank you all once again, and now we can conclude the session. Thank you.